evening. So, everybody, I hope you're well, and welcome to our webinar on the Rafaelo procedure and treatment for hemorrhoids. My name is Louise and I'm your host. You'll see on the screen we have our expert presenters, Mr. Marzouk and Mr. Adamek, the experienced consultants of general and colorectal surgeons at Benenden Hospital. Please note, within this presentation, there will be photographs of some hemorrhoids, so just so you're prepared for that. The presentation also will be recorded. After the presentation, there'll be a Q&A session where you can ask questions throughout the presentation or at the end through the Q&A icon at the bottom of your screen. This can be done with or without providing your name. So now I'll hand over to Mr. Adamek, and you'll hear from me again shortly. Thank you very much.
Thank you kindly for the presentation and welcome on one of the series of webinars. We hope to bring some information to all the patients about the hemorrhoidal disease, the development of the new techniques of treatment, and we try to share our experience of various modalities of treatment. Both myself and Mr. Marzouk, my esteemed colleague, done several cases of hemorrhoidal disease, and we can share our experience for the better understanding of the treatment and expectations to our patients. Let's start the presentation. Hemorrhoids treatment been running for centuries. It was well known since 2300 before Christ or 2500 before Christ, when patients were troublesome with the bleeding, discomfort, itchiness, and the leakage. The first operation was described in 2500 BC, and first time a hemorrhoid word was used in the English literature in 1398. It's a very common condition, frequent proctological disease, which occurs in various forms, which typical symptoms are itching, pain, bleeding, weeping, discomfort. 2 to 3 persons out of 5 in the Western world are affected by this condition. UK prevalence is 13 to 36%. 50% of those patients are aged 50 years and above. What are the hemorrhoids and why it happens? So they're like cushions around the tail end, extra protection seals to protect you from escaping from wind and the leakage. So hemorrhoid grade 1 stage are absolute physiology for all of us. They start being symptomatic when they start bleeding, or when we put too much pressure against the whole pelvic floor and against the cushions, when we get constipated, when you strain on the toilet, when you do heavy lifting, when the abdominal pressure rises and put that pressure against the pelvic floor muscles. Those are the muscles that support your bladder, your back passage, and then become troublesome. So repeated shearing forces with chronic straining constipation cause disruption of the elastic supporting matrix around the tail end, and all of this causing cushions to become swollen and prolapsing from the back passage. Based on the size and the position of the hemorrhoids, we can divide them into internal, external, or mixed, and then we grade them from grade 1 to grade 4. It's worth noticing that the grade 1 is absolute physiology for all of us, so we all have first degree of hemorrhoids. This is not a pathology, this is the physiology. Second degree when they're slightly swollen. The third degree when they're swollen, prolapsing, but they can be retracted back. And the fourth degree when they prolapse and they present outside the back passage, when they strangulated outside. And this is probably the only time when they are painful, when they're sitting outside, when the mucosa is sitting outside the anal canal, mucosa can get ulcerated and the pain occurs with it as well. At every single time they bleed. If they swollen, they prevent the anal canal to be closed properly with the muscle sphincters, and that happens that the mucosa start leaking from the back passage, start irritating the skin around the tail end, and other symptoms like itchiness and eczema happens at the same time. Bleeding is the most common symptoms of the hemorrhoids. Normally is a painless bleeding, normally bright red in color, which significance that there's bleeding coming from the distal part of the back passage or left part of the colon. Depending on the concomitant symptoms, We may need to do flexible sigmoidoscopy to make sure we're not missing anything else in the left colon. The blood is normally not mixed with the stool, normally happens at the end of the defecation, happens on the tissue, occasionally drips into the pan, and when it mixes with the water in the pan, it looks like a significant amount of the blood, but normally it's only a few drops mixed with the water and looks a lot. Tissue prolapses after the defecation, significance of the second and third degree hemorrhoids. Normally, they can be pushed back or they retract back on its own and do not require any other treatment. Mucus discharge happens with the hemorrhoids as well in the same time, and as I aforementioned before, itching of the perianal skin happens as well. As we discussed before, some hemorrhoids are painful normally when they large, when they prolapse, and when they sit outside the back passage. Sometimes they do thrombose, and they are really painful because they cause the tension of the skin around the tail end. This is highly nervous part of the body and cause a lot of discomfort and pain. Mild obstructive defecation symptoms, which means that you strain on the toilet because the engorged hemorrhoids are sitting there, may happen as well in the same time. Normally, we ask patients to be seen in the clinic. When we examine at the same time, we take the whole family history and whole history of the symptoms and the disease, the duration of the disease, the color of the blood, what's happening, and then we make the decision, should the further investigation be required, and what treatment can we apply once we make the diagnosis. We've been through the symptoms already, that they can be swollen, prolapsing, and painful when they're outside. When they bleed more and more, something needs to be done about it. When we examine the patient, we need to exclude any other pathology around the tail end, which we're talking about the cancer, thrombospirals, any other inflammatory bowel disease, and any other disease of the back passage, such as rectal prolapse or pelvic floor dysfunction. Treatment can be approached in stages. Normally, hemorrhoids do not require surgical intervention. Changing the lifestyle and modification of your diet will bring the improvement to your symptoms. Occasionally, we may need to put you on medical therapy. Then we can move towards the office-based procedures such as hemorrhoids banding, Rafaelo procedure, which is becoming more common and common now as an outpatient settings with local anesthetic without any sedation, or more advanced hemorrhoids, which require proper surgery with use of the theaters and general anesthetic. Lifestyle modification and medical treatment of hemorrhoids. We're talking about avoiding constipation, avoiding any strenuous activities, adequate hydration to make the motion softer and moister. Use the bronze to your diet to help everything be kept in the lumen and for the motion to travel smoothly through the large bowel. Occasionally, GP prescribes for you a local application of proctosedil or anosol just to help the ease of the symptoms. There are various surgical procedures which can apply to treatment of the hemorrhoids. We're not going to discuss all of them today. The most commonly used one as outpatient surgical procedures we will discuss will be rubber band ligation and the Rafaelo procedure, which is the main aim of our presentation today. The aim of this treatment is to reduce the amount of the redundant tissue in the anal canal, reduce the vascularity, cut off the blood supply to the cushions of the hemorrhoids, and trying to hitch that hemorrhoids, which will go up the anal canal and stop prolapsing. And then if the blood supply is cut off, the hemorrhoids will shrivel up. Any external components of the hemorrhoids which are sitting below the dentate line, which require general anesthesia, as these procedures are very painful. Rubber band ligation, known for decades, if not centuries, a very common procedure. When we apply anoscope into the back passage, we visualize the hemorrhoid and we apply a rubber band for the blood supply as seen on the picture. Rubber bands stay there for a few days to a week. Normally they drop after a while. And then you may notice a bit of bleeding, by which time the hemorrhoid should be thrombosed, and after a few weeks should start shriveling up and decreasing in size. New treatment for internal hemorrhoids called Rafaelo. The technology been used for long time now. It's been used for the laser vein therapy for the varicose veins, and now been modified to used for the hemorrhoids as well. The most common are first and second degree for the Rafaelo hemorrhoids, which can be performed at the outpatient settings. The third degree hemorrhoids also could be addressed, but I think they're slightly bit more pronounced and require majority of cases general anesthetics. The experience in the third degree hemorrhoid will be shared with us by my colleague Mr. Marzouk, which has performed several operations for the third degree. I've done majority of the patients for the first and second degree of the hemorrhoids under local anesthetic or bit of sedation in outpatient settings, and very few for the third degree under general anesthesia. So what is the Rafaelo procedure? It's a radiofrequency ablation of the hemorrhoids under local anesthetic. The probe produces a radiofrequency thermal injury to the cushion of the hemorrhoids to cut off the blood supply to the hemorrhoid. It's an outpatient setting procedure. It doesn't take very long. We inject a bit of local anesthetic once patient is in the room. Then we apply the probe into the hemorrhoidal cushion, apply the thermal application of the radio frequency via probe. And when we see the hemorrhoids are shriveling down and changing in the color, then we withdraw the probe and cool down the area with the cold Seton. Normal patient just get out from the couch and walk out of the room with the minimal discomfort, and we provide the painkillers to take home. That's for the first and second degree of hemorrhoids. That's the anoscope and the radiofrequency probe, which goes into the cushion of the hemorrhoids, which you can see on the left-hand side of the screen. And then on the right-hand side, you can see slightly whitish tissue after the ablation of the hemorrhoid once the probe has been removed. And then we wait for the final stage of the treatment, which takes place in the next few days. This is the device which is producing radiofrequency and the probe next to it. And this is step-by-step Rafaelo procedure explained what I just said. Anoscope into the back passage, then the local anesthetic on the picture number 2, which shows that the local anesthetic is injected underneath the hemorrhoidal cushion and above the muscle layers of the rectum, just to avoid any additional pain and injury to the muscle. Then the probe is inserted into the cushion itself, lifted off the anal wall, and the frequency ablation is applied. It doesn't take long. The temperature of the frequency ablation is around 100 and 120 degrees of Celsius. It lasts for a few seconds, and then we apply cold Seton to cool down that area. The ablation is applied in several places of the cushion, depending on the size of the cushion, but we start from the top of the hemorrhoids, and then we work our way down towards the lowest part of the hemorrhoid. All of this has to be applied above the dental line of the anal canal. That treatment does not affect the skin component, can be applied in 2 sites or 3 at most at any one time. Excellent results from the long-term follow-up. The recurrence rate is calculated between 12 to 18%. And the recurrence normally is on the other side than the treated side of the hemorrhoids. As you can imagine, the hemorrhoids are in 12 places in your anal canal. So if we treat 2 or 3 of them, you may develop hemorrhoids on another side of the anal canal if you don't change your lifestyle, if you still do constipation or heavy lifting and strenuous activities. Other surgical treatment, which were quite extensive, requiring general anesthetics, is open resection of the hemorrhoids called Milligan-Morgan. They are quite uncomfortable or painful for the patient for next 2 weeks after the surgery. And I tend not to see my patient, to be honest, for 4 weeks because they don't really like me for that time. But after 4 weeks, they start smiling and start appreciating the outcome of it. But in the first 2 to 3 weeks, they really are not happy. And I share that pain with them because it's quite a drastic procedure. We can do also an end-seal hemorrhoidectomy. Mr. Marzuk is an expert in that field. We used to do the stapling hemorrhoidectomy called PPH, but personally I have abandoned that a few years ago due to the long-term outcomes of the PPH. The other procedures are halo procedure, THD, and laser procedures, but all of them would require a general anesthetic. So for more advanced, more troublesome hemorrhoids with the mucosal prolapse, we've got various modalities of treatment, but those treatments would require general anesthetic, while the Rafaelo procedure can be walk-in and out from the outpatient settings. This is the end-seal. I'll ask Mr. Marzuk to comment on this procedure, please.
Yes, the end-seal is essentially a better way of cutting and sealing. So traditionally, hemorrhoidectomy, when you require more treatment, either because the simpler treatment has failed or the patient has larger hemorrhoids, and especially if they have a large skin component, they need some form of hemorrhoidectomy. And traditionally, this has started using just the scissors, then electric current used diathermy to cut and stop the bleeding. But the advantage of using this end-seal is that you could sort of almost tailor it to that you pull it, and then apply the jaws to it. It will first sort of burn it and cut it. But it has an advantage because the so-called thermal injury, or the injury from the heat generation or the coagulation of this machine, is actually quite limited. So as compared to other ways of coagulating hemorrhoids, it actually just seals the edges and bring them together without damaging any surrounding tissues. So we like it, but still it has the major disadvantage, like any of the other excisional hemorrhoidectomies, of causing significant degree of postoperative pain. And Jake has been very clear throughout this presentation, trying to say that we have tried to move away from excisional forms of hemorrhoidectomy into other simpler treatment, because the excisional hemorrhoidectomy tend to be quite painful, but it's also very effective. And exactly like Jake said, I also try to avoid patients. I tell them in the clinic that you will hate me for 3 to 4 weeks and then you will love me afterwards. Very similar story. Back to Jake.
Thank you. So one has to realize that one size doesn't fit all. So that means that Rafaelo won't be suitable for every single patient who will come with the hemorrhoidal symptoms. Each procedure which needs to be tailored to the stage of the hemorrhoids and the symptoms of the hemorrhoids. We will answer all those questions later on: who is suitable, who is not suitable. Let's run through the postoperative complications, if any, after hemorrhoidal treatment. Pain or discomfort after the Rafaelo procedure is one of those. A small amount of bleeding may be experienced for the patient. Occasionally, they can notice a bit of ulceration at the site of the treatment of the hemorrhoids. What's most important for the postoperative is to have the regular pain killers to be taken for the next 3 to 4 days on a regular basis, and then as required, avoid constipation, regular motions, and keep the site clean. Otherwise, no further major complications noted whatsoever. As I said, one size doesn't fit all. So then when we see the patient and we assess the hemorrhoids, then we'll make the decision what would be the best suitable, most successful procedure for the stage of the hemorrhoids you present in the clinic. And the hemorrhoidal treatment for the internal hemorrhoids, Rafaelo will be absolutely fine, but for those who are prolapsing to the 3rd or 4th degree, they are more advanced. So 3rd degree sometimes can be treated with Rafaelo, but would require general anesthetic. 4th degree is not suitable as they're sitting outside the anal canal, and we cannot apply all this frequency ablation with the heat into that area because it's extremely painful and wouldn't be tolerated by the patient, and the outcomes are not that great. Anyway, hence we got the other modalities of treatment, including NSIL or the open hemorrhoidectomy as the last stage really of the treatment. We can open the session of questions to the audience, please. We're happy to answer should you have any.
Thank you very much. I will go through the questions now, if that's okay. That's a really interesting presentation, so thank you. Our first question is, am I allowed to drive myself home after the Rafaelo procedure?
I can answer, yes. So if you have under local anesthetic and no sedation, by all means, yes, if you feel comfortable. If the sedation is given, then absolutely not. You have to be driven home and somebody must stay with you at home, exactly the same as you're coming for colonoscopy with sedation. Excellent,
thank you. And the next question is, what is the difference in recovery time for Rafaelo versus, say, a hemorrhoidectomy? Mr. Marzouk, would you like to answer this?
It's a big difference. Rafaelo, if you do it in first and second degree hemorrhoids, the patient will actually, if you see them in my early patients, I decided to see them after a week, and some of them reported no pain at all. Some reported some discomfort for a day. So the recovery tends to be in matters of days. Even those who have had Rafaelo under a general anesthetic for very large hemorrhoids, it was their choice, they still reported some degree, maybe maximum couple of days, and still recovered after that. It is consistent with all conventional hemorrhoidectomies that the patients will have significant degree of pain. And obviously patients are different in their threshold and pain tolerance. So some patients would be just tell you that they had a pain for about a week. If you have, say, treated one site, but if you have treated 2 sites or 3 sites, a lot of them would really report significant degree of pain for about 3 weeks. And I think the issues here is that if you tell the patient honestly about this, they are more prepared, because if they don't know this, they think there is something wrong happened with the operation. And so it is vital that they know the difference. And this is not to try to sell the hemorrhoids and undersell the traditional hemorrhoidectomy, because they are really very complementary. They cover different types of hemorrhoids, and they are not really direct competitors. But it is very important that when you see a patient, you try to be as honest as possible and define what you're trying to achieve from this treatment and give them a realistic outlook to what they should expect.
Thank you. Mr. Adamek, is there a long waiting list on the NHS for procedures like this, as I'm weighing up paying or waiting and the benefits for each? Could you cover that off?
Well, due to the COVID, there's a massive backlog in NHS, and of course the procedures in NHS are prioritized depending on the urgency and the severity of the cases. So of course the cancer cases take the priority. I'm not saying hemorrhoidal disease is not important, but it's not lethal. Therefore, they're going to be postponed to the later stage until we clear out all the backlogs with these serious conditions to be treated. So all in all, I think the answer is yes, the waiting list is quite significant.
Thank you. Okay, Mr. Marzouk, how do I know if I need Rafaelo treatment for my hemorrhoids?
I think the most important thing is that the patient need to know what is his real and dominant symptom. So if the patient comes because they are having difficulty in cleaning, or because they have itching, anything to do with the skin, they are not suitable for Rafaelo. Rafaelo is designed purely to control bleeding, although even in advanced state, it does shrink, and the hemorrhoids will actually shrink a bit inside, but it will still leave a lot of external hemorrhoids. So if the patient main symptom is a lot of bleeding, then the Rafaelo may be suitable. Even those who have one side prolapse, like sometimes a 3rd degree prolapse will occur only at one single site, they may still benefit to a degree from the Rafaelo, provided they actually have a realistic expectation. They understand it is mainly designed to shrink it a bit, to stop the bleeding, but not to remove any significant prolapse or any external component.
Okay, thank you. Mr. Adamek, this person says, I've had hemorrhoid treatment before and they have returned. Does this treatment have better outcome or results?
So Rafaelo is, again, not one size fits all. Depending on the size of your hemorrhoids and the place of the hemorrhoids, we can offer Rafaelo treatment. As I said, the successful rate is about 82%, as in compared to the ligation of the hemorrhoids, which the failure rate is about 60%. So this is a very good, efficient procedure, but it has to be assessed on case-by-case basis, depending on the symptoms and presentation at the time.
Okay, thank you. Mr. Marzouk, are there any side effects to having this treatment?
Sorry, say that again?
Are there any side effects to having this treatment?
No, if it is done properly, making sure that when we inject a bit of anesthetic to separate it from the muscle so that because essentially the Rafaelo sort of cooks the inside of the hemorrhoids and sometimes the surface as well. So as long as it is separated from the muscles, it doesn't damage the muscle anyway. The degree of discomfort, as I mentioned, is minimal. And occasionally a patient may bleed, again, 1 or 2 days, but this is the same with any hemorrhoidal treatment. One has to take adequate history, make sure that the patient is not on anticoagulants or something like that, which may become problematic if the patient restart the anticoagulants because whether you do an open hemorrhoidectomy or Rafaelo, there is a chance that there may be part of the hemorrhoid will sort of form like a scab and then fall off. And if the patient is anticoagulant, they will bleed. So in general, very minimal discomfort, occasional a spot or 2 of blood, but very rarely if the patient is on anticoagulant, they may actually bleed a little bit more. But that should be anticipated and warned. The patient can be warned, or we can manage that.
Lovely, thank you. Mr. Adamek, how long does the procedure take?
All depends how many hemorrhoids we're going to treat, but all in all, about 15 minutes since they're entering the room to the leaving the room.
Great, thank you. Mr. Marzouk, how would I prepare beforehand for that Rafaelo procedure?
You make sure that you understand the aims of treatment and make sure that your expectation is correct in terms that you should not expect that the Rafaelo will cause you to have a shrinkage of skin tags, for example. In general, the patient, if they are coming to be done under local anesthesia, they don't need any special preparation. Even when they come to have it under general anesthetic, because you have very large and multiple sites, and it is preferable to do it under a short general anesthetic, we now prefer not to give the patient any preparation, because if the patient gets an enema, it just becomes messy during the surgery. It's actually more easier to do it without preparation at all. So patients just need to come and have the operation, and it should be all right, actually.
Okay, thank you. Mr. Adamek, what kind of lifestyle changes can I make to avoid hemorrhoids? So,
as I said, have a regular motion on the softer side, avoid constipation, have plenty of fluid to moisture your motion. Any strenuous activities when you can avoid, which put a lot of pressure in the abdomen and then transfers it down to the pelvic floor, that's very important. Losing weight, very important life changes to avoid hemorrhoids. Loads of hemorrhoids happening during pregnancy. Is it due to the pressure of the pregnancy development itself and pressure against the pelvic floor? So simple measures make a big difference.
Okay, thank you. Only a couple more questions to go. Mr. Marzouk, we have a question. Can I choose what anaesthetic I would like? For example, local, mild sedative, or general?
Yeah, yes, by and large, we are happy to offer Rafaelo for first and second degree hemorrhoids, 1 or 2 sites. But if the patient, because a lot of the early patients that have come to Benenden actually came with hemorrhoids outside the classical indications for Rafaelo. And if they have really, I've treated some with circumferential hemorrhoids with Rafaelo, and these patients actually, ideally, they should be treated with general anesthetic for a simple reason, is because the amount of energy used to cook the hemorrhoids at multiple sites, it becomes too much. And it is sometimes we give them more local anesthesia. So it's a bit more involved procedure. It still takes about 15 to 20 minutes. It's not long, but it is a bit more involved. So by and large, yes, the patient can choose unless we say this may be too much for you. If we're talking about excisional hemorrhoidectomy, if somebody comes with skin tags or an external component, they still can have it done either a spinal or epidural or a general anesthetic. Local is possible, but only possible for really small skin tags. It's all to do with how much the patient can tolerate the injections, because even the local, if you do it in the skin, it can start to sting first before it numbs the area. The injection, that local anesthetic that we use in first and second degree Rafaelo, is given essentially in a numb area of the body. But if you inject in the skin around the back passage, that's much more painful than that injection. So by and large, if it is excisional hemorrhoidectomy, some form of a general or spinal anesthesia is acceptable, even something called caudal block, which is a special form of local treatment that has to be given by an anesthetist. But if we're talking about the Rafaelo, a large majority of them can be done with simple anesthesia. But if, on the other hand, a patient is very anxious and wants to be asleep, we can accommodate that as well.
Great, thank you. Very good comprehensive answer. Our last question, which I will pose to you, Mr. Adamek, is will I need to return to the hospital after the procedure for a follow-up consultation?
So we got a regular follow-up for the patients, and we try to see them within a week and then after 6 weeks and see what is the outcome of the treatment. By following that protocol, then we can collect the data, treating the same way and following up the same way. So when we present our data, it's comprehensive data and it's comparable.
Okay, thank you. We just have one more comment. Thank you for a really helpful presentation. I'll tell you who, but they are very, very appreciative.
Sorry, we didn't hear the one. You break out.
It was just a thank you from an anonymous person for the presentation. They said it's very helpful. So
Thank
just
you.
to pass that on. So yeah, from me, it's thank you so much, both of you, for the presentation, for your time and your knowledge. It was really interesting. If anyone else does have any more questions that they didn't have the chance to post, or they felt a bit embarrassed, please do email them to the email address or the webinar email address, the address on your screen, and we will get through them. At the end of this presentation, you will receive a short survey, and we're really grateful if you could spare minutes just to give us your feedback on today's webinar. It will help us improve future webinars. Our next online event is on Wednesday, the 6th of October, so next Wednesday at 7 p.m. It's with consultant gynecologist Mr. Gupta and clinical nurse specialist Jan Chaseley on continence care. So on behalf of Mr. Marzouk and Mr. Adamek, myself and the team at Benenden Hospital, I would like to say thank you so much for joining us today, and we look forward to seeing you again soon for another webinar. So thank you very much. Goodbye.
Thank you.
Kindly. Likewise.
Thank you.